It's really my pleasure to keep on coming to World Neurosciences Summit here. Dr. Arun has asked me to talk about some cases on atypical Parkinsonian or Parkinson mimics. We have played it, some issues with the videos we had, so finally I made a quick change in my presentation, but it will be definitely of interesting for all of you, mainly because this is what happens down here. So what we are going to talk about, a lot of us, we manage our patients with Parkinson disease with various types of medications going on. We need to know what is happening to our patients, what dosages we are giving, and how we compare with other patients across the globe. So when you look into Parkinson disease, these are the standards of treatment, which all of us know, which includes medications, which includes pumps and surgical press, and whatever the newer therapies comes down there. These are the various types of medications and therapies which are being utilized for management of patients with Parkinson disease. However, it's not same across the globe, because when we treat patients with Parkinson, all of us know levodopa is the gold standard. But when it comes to the availability of medications, there are a lot of variable factors which play a role, how it works out. It may be some government regulations, because for some countries, even levodopa is not yet available. There may be cost, which may be, because let us say duodopa pumps, which is not available. Apomorphine, which is being told not very commonly used, mainly because of the cost which is involved down there. Or it may be treating doctor preferences, where you are practicing in a tier 2 city, tier 3 city, how you look into it, what is available, what is the best way to manage a given patient for you. Because this is where a difference makes for you when you are going to manage a patient with Parkinson's disease. How are you going to decide? And the insurance coverages. In Western countries, what is covered by their insurances, what is the co-pay associated with that, those things makes a difference. And sensitivity of the patient. What is there a genetic sensitivity for them? Whether they can tolerate certain medications, certain geographical regions have more sensitive to certain medications. So all these factors make a difference how when we start treating the patient with a Parkinson's disease. But when we start doing this, how to compare what treatments are going on, whether these are right, these are wrong, and if you want to compare a patient who is treated in India to see, for an example, for a patient treated in Kenya or a patient treated in US or a patient treated in UK, how are you going to cross compare that? So this is where the concept of levodopa equivalent daily dosage concept has come. So what it does is, whatever treatment you are giving, with whatever permutations you are doing it, we can try to combine that into one single formulation, one number will come out, and that you can try to cross compare into that. This concept came first in 2010, when Tomlinson gave all the certain list of medications and then gave what are the common ways to, what are the available, what you call it as conversion factors, which we can multiply to whatever therapies you are giving it, and calculate the levodopa equivalent dosages. So this was the first broad general guidelines on LEDD. It included most of the medications which are available till 2010. Yes, it did miss out certain medications. Let us say anticholinergics was not involved there for a calculation, which we commonly use in India. That is what is the point. If you see, most of the patients in India with Parkinson's disease are being treated with anticholinergics. Then fast forward to now, what has happened in last almost like 15 years, number of medications which are being used to treat Parkinson's disease have changed, the type of therapies have changed, and this required an add-on to the initial conversion practice which was being suggested. So then in 2023, Jost et al. Came up with an extended formulations which included all the newer medications and some of the medications which were being missed. The question came here is, how much is the difference? Because are the newer therapies are there in practice? How much is the difference between Tomlinson's to Jost et al.? And how it is differs from across different countries when we treat it. To answer this question, we wanted to look into it, how to manage those things. Before going into this, these are all, I'm not going to deal into all the conversion factors, what is going on. Just I'm going to tell you that the yellow ones are with the, which came with the Tomlinson's criteria. Then the blue ones were with the Jost, which were added up. The drugs with asterisks, they means that they have to be calculated slightly differently than just by multiplication. For example, trihexyphenidyl, when you look into it, it should be a meaningful dosage. A meaningful dosage is considered as an equivalent of 100 milligram of levodopa to calculate. I'll recommend you to go through that both the articles to understand how these conversions are being done. So this is whole concept of what is now available with all these older drugs and the newer drugs, what is going on for management of Parkinson's disease. So what we needed to do with this, we needed to check how treatment happens across different countries. We needed to have some raw data to understand. So we needed to have LEDD patterns across different geographical territories and ethnic populations. And is there any differences? Is there a difference between the previous and the new? Means how much is the newer method is adding up to understanding of this levodopa equivalent daily dosages? And what new informations we capture those things, if it is there. So what we did was, we went across 6 countries, 2 different continents to collect this data. So we collected around 2,943 patients who were being treated for Parkinsonism disorders, out of which 2,557 patients were on levodopa. And then we try to look at it. Almost if you look into it, we fairly like this whole countries what are being represented, they represent around 3.25 billion population of the world population as against the total world population of 8 points. So let us say somewhere around 40 to 50% of the world population, probably this can be a sample to be extended if you want to consider in that way. These included from South Asia, we had Sri Lanka, India, Nepal, Bangladesh, and Thailand, and Bangladesh. From Southeast Asia, we had Thailand, and from Canada, we had 2 centers from Canada who were recruiting the cases for this. So out of all these things, what you can see is this, among 2,943 patients, 2,500 plus were with Parkinson's disease, with a mean age at onset of Parkinson's disease being around 56 years, and mean duration of symptoms being around 97, means around 8 to 9 years. That's what we are looking around. So what we found out, so when we try to compare, I'm not going to tell, this is just a general table which shows about how each one of the patients were differing and what was happening in. If you look into it, at the age at onset, when you look at it, India had the youngest age of onset of patients with Parkinson's disease, around 53 years, that's what you can notice down there. And when we looked into the levodopa equivalent, all these patients, we took whatever the medications they were taking at that point of time and converted them into a levodopa equivalent daily dosages, and we compared. On an average, people were taking about 609 milligrams according to Jost et al. Formulation, and around 597 milligrams according to Tomlinson et al. So there was about 10 to 15 milligram, but this 10 to 15 milligram was statistically significant, what we could notice down. And what you can see that the primary medication remained levodopa. However, based upon the countries, the primary medications vary. For example, if you see, Thailand had around 667 milligrams of pure levodopa. We found that Thailand had higher dosage of levodopa equivalent daily dosages being utilized as against any other countries what it went on. So, which medications were commonly being prescribed? As you can see, levodopa remains the standard and the first line of therapy across all the countries, what you can see. And following that, you have other medications where dopamine agonists will come down and anticholinergics do come down the picture. And most of the newer medications, what you can see, very few patients, it's not like commonly used medications or interventional therapies are not commonly used as such. So, what did we see? We tried to compare them across different continents, Asia versus North America. Let us say what is the difference between them. What we found out was Asians tend to have younger age of onset. Probably India contributed predominantly into that. Age of onset in Asians was around 55 years as against to 57 years in North America. Then what you can see that the levodopa dosages what was being utilized was significantly different. In both the Jost and Tomlinson's conversion formulas, it was around 640 to 620 to 640 milligrams in Asia as against to 550 to 560 milligrams in North America. So Asian population were using higher dosages of levodopa or levodopa equivalent daily dosages as compared to the North American data what we are having down. This significant differences becomes more important when you look into country-wise basis here. What you can see the bar chart down there, India and Thailand, when you look into it, they have significantly higher dosages what are being used for levodopa. It may be ease of access, it may be the prescription pattern, which makes a difference, but this is where we stand out. That is what we can notice down as such. Then we wanted to see, forget about the geographical pattern, is there a difference based upon age at onset? Let us say what is happening for a juvenile onset. Juvenile onset of Parkinson's disease is patients developing Parkinsonian symptoms less than 20 years or 21 years of onset. And those early onset is between 21 to 50 and regular onset is more than 50 years at onset. What we noticed was duration of symptoms, because juvenile onset patients had a longer follow-up as compared to other set of patients, what you can notice. And what you could notice, surprising was the early onset PD, the middle cohort who had the middle onset, they were the one with the higher dosages of levodopa. As you would have expected, people with a longer duration probably might be taking higher dosages, or people with shorter duration might be, or later onset can be taking higher dosages or lower dosages. But somehow it appeared that early onset between 21 to 50 years, these were the patients who were typically taking higher dosages of levodopa. Why? This could be due to multiple factors. One of the factors could be that these people are professional, working lifestyle. They are trying to push themselves to work better, to see what best can work out for them. So in that context, they keep on increasing the dosages of medications. And not only that, it's not only the levodopa dosages what you can see, the primarily non-levodopa component is higher in these early onset Parkinson's disease patients as against the juvenile onset and regular onset Parkinson's disease patients. So somehow these are the patients probably will be taking more dopamine agonists other than levodopa. Other combination of medications will be more common as well. So this is where the crux of all interventions would be going on. Everyone is trying a newer medication as soon as it comes out to try it out. So that is where we are surprised to see that this was a subset of the patients where treatment patterns vary dramatically. Then we try to look into gender-based differences. I think in gender-based differences, there was not much of a difference, except for that the overall dosages wave, mainly it could be, there was no differences in age at onset, duration of symptoms. But when we thought that why Jost and Tomlinson method may have differed, could be that it could be body weight related or genetic predisposition. So men tend to probably require higher dosages as women, just because of their whole body mass index, what is required and the dosages required along with that. Or it could be genetic predisposition, but that is what we found out a difference down there. Then what happens? How the treatment pattern changes with the time. Let us have how long you keep on increasing the levodopa when you keep on giving the patients. What we saw that there was a linear increase in the dosage of levodopa during the first 7 to 9 years. So dosages kept on increasing. And after that, it almost gets plateaued down. Let us say after about 8 to 9 years to almost next or 10 plus years, minor changes can happen here and there, but most of them were almost like plateaued off. So the role of levodopa escalation, because it indicates that non-levodopa symptoms becomes more and more prominent, and you are spending more time in managing non-levodopa responsive symptoms as against primarily levodopa, because you have reached a plateau and which is working consistently. This is what was an interesting finding, what we found out down there. Then, is there a difference for people who undergo surgical therapies and people who develop motor complications? For example, dyskinesis. Dyskinesis, we are not surprised. We found that about 30% of the patients had developed dyskinesias, and most of them had developed symptoms were documented around 6 to 7 years of symptom onset. And typically, they had higher dosage of levodopa, which was all acceptable with the current standard of knowledge what we are having. But when it came to surgical interventions, we are slightly surprised. I think it shouldn't be surprised, because I think the best answer is we were not well read enough. That's the best way I can tell it at that point of time when we are doing this analysis. So there are about 134 patients who had underwent surgical therapies, and commonly when we tell our patients who undergo surgical therapies is that your levodopa dosages will go down, you will become better, levodopa equivalent dosages. Yes, that is perfect. That is just comparing pre-surgery to post-surgery within the first year of the disease management. But down the time, what happens is, it's not the same. When we followed them up, when these patients who had underwent surgeries, when we followed them up, they typically had higher dosages of levodopa equivalent. You can notice that they were almost like 700 milligrams than an average of around 550 to 600 milligrams, what we used to see in other similar subset of patients. So normally what might be happening that these are the patients who are expecting more, you treat them and you keep on trying it to modify. At one point you feel that DBS is working, but it has reached a plateau phase, you start once again, the levodopa starts building up down there. Not only that, these patients had higher, there was a significant difference between Jost et al. And Tomlinson et al. That was Tomlinson et al. It was around 700 milligrams as against Jost et al. 761 milligrams. So it indicating that these patients are taking more newer therapies than the levodopa. So you are giving levodopa, but you are all adding up whatever the newer medications are coming down. That is where these differences are coming out. So this indicates that yes, surgical therapies are more patients who are looking for better outcomes. Whenever the therapy comes, we try to push them to make better, and down the time we should remember that the standard answer what we give about reduction in it, that holds good, but the first 1, 2 or 3 years probably. After that, the dosages will start creeping down because the plateau effect of the DBS or a consistent stability is there, and we need to modify them or manage them in a different way. So what we found out based upon these things is, one thing is what we can tell now based on when we compare them intra and inter, we found consistencies in therapies when it came to LEDD as a better. LEDD is a better to compare PD overall when you come to try to compare across the geography. So it's a good way to have these conversion factors then to understand. Otherwise, we keep on talking in different forums that, okay, Indian patients take only 200, they are sensitive, some ex patients take 500 and they're different. But there may be addition of other things which may be based upon availability of medications and various other factors play a role. What we also felt, there is a definite disparity or differences are there on territorial basis, age at onset basis, and more aggressive therapy happens for those people who are between 21 to 50 years of age at onset of Parkinson's disease. These are the subset of patients probably taking higher dosages of medications, not only levodopa, even newer medications which are non-levodopa, which adds up to the understanding of that. And what we found out is non-levodopa components were highest in Thailand and India, 234 milligrams versus 169 milligrams, what you know. As against other countries, we found it which was less than about 100 milligrams, indicating a prescribing and availability pattern. This shows how general practice is happening. You have dopamine agonist available, you have anticholinergics available, you have COMT inhibitors, you keep on prescribing them, you keep on adding up to them to manage without increasing levodopa. This is what the differences, what it picks up. That's what is more important when we are looking into those things. And post-surgical patients tend to be higher dosages of levodopa and non-levodopa components. It may be related to longer duration of PD or higher expectations, what we could notice down there. Thank you. Thanks a lot. This was a small, interesting talk about how the levodopa equivalent dosages changes, what we practice, what happens in India as compared to other countries. It gives a bird's eye view peek on what is going on. Thank you. Thanks a lot.